Let me expand upon our key study findings. So, from a biological perspective, previous studies have shown that POLE mutations are related to other favorable predictive factors such as high expression of PD-L1, high TMB, and infiltration of CD8 positive cells in the tumor microenvironment. In our study, the high TMB driven by POLE mutations could potentially explain the early and sustained ICI treatment response. Previous studies have also assessed non-synonymous variants in POL-E and POL-D1 as potential biomarkers for response to ICI, where they independently predicted extension of overall survival after accounting for microsatellite stability and cancer type. In our gallbladder cancer patient with a non-EDM POLE arginine 150 stop mutation, it seems that there might be TMB and MSS independent pathways which could promote immunosensitivity in these specific patients, leading to improved survival. And this is a hypothesis which should be explored in future investigations as well. Also, in our CRC patients who had both poly-EDM and poly-non-EDM, which potentially contributed to the clinical benefit with the ICIs through complementary biological pathways. So, taken together, these early results suggest that in addition to poly-EDM, patients with poly-non-EDMs could also serve as potential biomarkers to identify ICI responders. I should also share that from a clinical perspective, decisions regarding immunotherapy duration, the timing of surgery after immune complete metabolic response, and treatment modification or discontinuation were individualized and made within specialized MDT meetings. Since there's a lack of established guidelines for poly-mutant GI cancers, treatment duration was guided by sustained radiological and metabolic response, clinical tolerance, and patient preference. Surgical resection was recommended only after prolonged and durable metabolic remission with the aim of confirming pathological response and to maintain disease control rather than as a predefined treatment endpoint. Our observations are meant to illustrate a personalized response adaptive management approach in a rare molecular subset. In our study, we highlight the importance of integrating liquid biopsies both at baseline and follow-up as part of the standard clinical practice to identify GI cancer patients with rare POL-E mutations as they can benefit from immunotherapy, which has led to complete metabolic response in addition to radiological responses and extension of survival in all of our patients. In a subset of GI cancer patients with a challenging prognosis, we also advocate for specialized MDT teams performing shared clinical decision making to advance personalized care and improve clinical outcomes.